So let's quickly learn a few points about beta blocker and calcium channel blocker toxicity. First, about beta blocker toxicity. How beta blocker acts is by blocking the beta receptors, right? Beta blocker toxicity has main implication on the heart. Alright, so let's see the action of beta receptors in our heart. Alright, so beta receptors, they are bound to GS proteins or glycoproteins, stimulatory glycoproteins. So whenever a beta agonist binds to the beta receptor, especially beta 1 receptors on myocardium, it stimulates the GS protein. GS protein in turn activates an enzyme called adenylate cyclase. This adenylate cyclase helps in the catalysis of conversion of ATP to cyclic AMP. The cyclic AMP will act as a second messenger, which facilitate phosphorylation of calcium channels, the L-type calcium channels in the membrane, myocyte membrane. The stimulation of calcium channels will result in a rapid influx of calcium into the myocyte. This calcium cause, we have already seen this in digoxin toxicity. This calcium can cause calcium-induced calcium release from the sarcoplasmic reticulum. And the large increase in the calcium concentration inside the myocyte will result in actin-myosin contraction. Alright, now whenever you give beta blocker, the intracellular calcium concentration is reduced, so the contractility of myocardium is also reduced. So why do we even prescribe beta blockers? See, if patient had already had a myocardial injury, you need to reduce the work of this injured myocardium. And for that, we are prescribing beta blockers. So what happens in toxicity? In toxicity, the exaggeration of this pharmacological effect is seen. Alright? Now, beta receptors are found throughout the body. Beta 1 receptors are more commonly present in the myocardium. Beta 2 receptors are more commonly present in the smooth muscle, skeletal muscle as well as the liver, and beta 3 receptors more commonly present in adipose tissue as well as the skeletal muscle. Now, beta 1 receptors are involved in the myocardial contractility. Beta 2 receptors are involved in smooth muscle relaxation like vasodilatation, uterine relaxation, and even bronchodilation. Okay, so whenever these receptors are blocked by beta blockers, the exact opposite effects will be evident. So in beta 1 receptors are blocked, of course there will be decreased myocardial contractility as well as slow conduction in the myocardium. Okay, now you can see that there are a lot of beta blockers available in the market and the properties are somewhat different. So the toxic effects will also depend on these varying properties, which drug has been taken in an overdose by the patient. Alright, so for example, propranolol is the worst beta blocker which can result in beta blocker toxicity. Why? It is because it has additional sodium channel blocking activity. So in addition to blocking the beta receptors, it blocks the sodium channels as well in the myocardium. This can lead to QRS widening and it can lead to ventricular arrhythmias. So usually beta blockers will result in bradyarrhythmias, but propranolol toxicity can result in ventricular arrhythmias. Just like that, sotalol is another beta blocker which has additional potassium channel blocking activity, which can result in QT prolongation and thus ventricular arrhythmias, especially Torsades depointing. So these two medications, beta blockers, can result in tachyarrhythmias. Then one other property we need to be knowing about is the lipid solubility of these drugs. Drugs like propranolol and carbidiol are very much lipid soluble and they can easily cross the blood-brain barrier. So once in the blood-brain barrier has been crossed, these drugs can cause a direct toxicity on the brain. So it can result in decreased sensorium, confusion, sometimes even coma, and it can also result in seizures. So because of sodium channel blocking property of these drugs, they can also cause seizures in the brain. Alright. Then another important thing to remember is that some of these beta blockers has also got additional partial agonistic activity. So some of these drugs, even though taken in a high dosage, may not result in that much bradycardia with hypotension because of the agonistic activity. Now you can see that a lot of beta blockers are receptor specific. Most of the drugs which we are prescribing now are beta 1 specific beta blockers, right? But in overdose states, all these drugs lose their specificity and they can act on multiple receptors. So that's also one thing we need to be knowing about. Alright. Now coming to the clinical features, the hallmark is going to be the slow and low state. There will be profound bradycardia with hypotension. And this is because of the decreased myocardial contractility and slow conduction through the conduction system of the myocardium. Alright.